Chest films. I told you about plain films when we talked about the spine, and I showed you some plain films of the lumbar, thoracic, and cervical spine. And plain films are still done nowadays from time to time with the spines, but it's not nearly as common as it used to be. On the other hand, plain films of the chest are very, very common. They're part of a standard chest film. You can't even get a job at this hospital without having a chest film. And so you have to understand how they're done, and we have to be able to read. Or you have to be able to read, I don't have to, a chest film. A patient puts her chest up against a device that has the sensors for the x-rays, and the x-ray tube, schematically drawn, sends x-rays through her back and out the front of her chest to hit the sensor array. Therefore, this is called a PA chest film, because the x-rays travel through her from posterior to anterior. That is not the only kind of chest film you can have. Here's a chest film that is done quite often on people who are sick and in the hospital, where the sensor plate is put on their back, and the x-ray tube is up above them, and the x-rays travel through their anterior surface before exiting the posterior surface, and that is called an AP chest film, and often called portable, because most portable chest films are AP. You might think to yourself, well, that's fine. I know if there's a PA chest film, I'm looking at the front of the person. If I know it's an AP chest film, I'm looking at the back of the person. But of course, you also know that that's completely crazy. These are two-dimensional images you're seeing. There's no front or back that you're seeing at all when you look at a chest film. All right, you're seeing the whole thing compressed into two dimensions. Now, there is a slight difference between the way things look on PA and AP chest films, and it has to do with the fact that here's the source of the radiation, and here is, the image that will be produced. If you have an object that is far away from the sensor array or film, I call them chest films, even though it's not done on film anymore, but still they're called chest films. So if you have an object which is far away from the film, the X-ray beams, because they diverge, will produce a slight magnification of that object and a slight blurring of the edges compared to what would happen if that object were sitting just a tiny bit above the sensor array or film. So in fact, PA films are done for one and one reason only. The object you're almost always most interested in when you do a chest film is the heart. And as you know, I hope, the heart sits at the front of the chest, and therefore you want it to sit as close to the film as possible so it is not artificially magnified, and so its edges are nice and sharp. If a person has an AP chest film, then the heart is going to be somewhat blurred and somewhat magnified. But you have to be a better person than I to figure this out. These are actually not of a normal person, PA film, and a person with a big heart, PA film. These are the same person taken, where the one on the left is a PA film taken with them standing up, and the one on your right is a AP film with them supine. I cannot see any blurring of the edges of the heart, but it's clear that the heart does look bigger here than it does there, and you would, if you were not told in advance, and you have to be told in advance what kind of film has been taken for you to interpret the size of the heart correctly in relationship to the rib cage. So it's important that you know that for the reason I just explained. Let me try this. All right. Also, something you have to know about is what's the state of or inspiration or expiration of the patient. Now, in fact, you're not going to be told this unless something goes wrong. Always people, when they have PA chest films done, or any kind of chest film, the patient is asked to take a deep breath in. All right, and that's to expand the lungs as much as possible. And that's what you get. But if a person is sick and can't do it, it's really nice to know, because obviously things don't look the same. If you can't take a big deep breath in, the heart gets squished up and is flatter. The lungs don't seem to go as far down and things like that. So it's good to know the state of the if a person has failed to make the proper inspiration. because that's going to affect the way things look. I'm reminding you, as I said earlier, these are two-dimensional things. You cannot tell when you look at this where that bullet is, towards the front or towards the spine of this person. In fact, that's why everybody who has a PA chest film also has a left lateral chest film. Why left? Why left, do you think? Yeah, because the heart's on the left. And you want the object that you want in sharpest focus to be closest to the film. So left laterals are what is done, so the heart is in clearest image. And then when we do look at the x-ray of our person who had the bullet, we already know that the bullet is up just deep in the manubrium, in fact, in this individual. Now, silhouetting. It's a concept that some people find hard to understand. There are these basic densities I told you about: bone, water, fat, air. All right. You can only tell the border of two things which lie next to one another if they have different radio densities. If two things lie next to one another and have identical radio densities, you cannot tell them apart. All right? Two things which lie next to one another and have different radio densities so that you can tell them apart are said to silhouette one another. This is a term of art that radiologists use. All right? They are said to silhouette one another. For example, the reason I can see the anterior border, this is a left lateral film. The reason I can see the anterior border of the heart here is because it silhouettes against the lung, which is full of air. So it's air density against water density. The reason I can see the back of the heart here is because it silhouettes against the lung, which is air. Different radio densities. The reason I can see a vertebra, the upper and lower boundaries of the vertebral body, is because it silhouettes against the intervertebral disc. That's water density versus bone density. Yeah. Now, this thing here that I've drawn arrows to is part of the diaphragm. You haven't dissected the diaphragm, but you know, they must know what the diaphragm is by now. I mean, it's what the heart sits on, all right? And the reason I can see the upper surface of the diaphragm is because it's silhouettes against the air density lung. The diaphragm is routinely said to have a left half and a right half. They're innervated separately. The left half is called the left hemidiaphragm. The right half is called the right hemidiaphragm. You can see the two hemidiaphragms as separate structures. You can see it here. And here's the other hemidiaphragm. On the left picture, here's one hemidiaphragm. Here's the other. They're not sitting at the same height, typically. But the question is, how do you know which is which in this image? Look at this hemidiaphragm. Let me trace it. I can trace it, and then I can't trace it anymore. Let's take a look at the other one. Trace it, all the way to the front. The reason that's the case is because of silhouetting. The heart is water density. The diaphragm is water density. When the heart overlies the diaphragm, you cannot see the boundary between them. They do not silhouette one another. So as you're tracing the left hemidiaphragm forward, it loses its identity as a structure when it merges with the shadow of the heart. So very clearly, this is the left hemidiaphragm. All right? And that's because I know I can't trace it forward once the heart is there. This one, which I can trace all the way forward, is silhouetting against the right lung, which has air in it all the way to the front. There's no heart of consequence on the right side. So you can see the right hemidiaphragm all the way from front to back because it silhouettes against the air in the right lung. Now there is something called the silhouette sign. The silhouette sign is when two structures, which normally silhouette one another because they have different radio densities, fail to silhouette one another because some pathological state has caused their radio densities to be the same. I can say that, but it doesn't come across as meaning anything the way I say it. So I'm going to show you a couple of examples of the silhouette sign. It is the absence of a silhouette when you expect to see one. It's a strange way they should call it the anti-silhouette sign, but they don't. They call it the silhouette sign. Now, you have not dissected the lungs yet. But these are the lungs sitting in a drawing of the lungs sitting in place in the chest. And right lung has an upper lobe and a middle lobe and a lower lobe. And the left lung has an upper lobe only, in the sense that there is no middle lobe on the left side, has only an upper and a lower. These lobes can be independently involved in pneumonia. You can have an upper lobe pneumonia of the right or left side. You can have a middle lobe pneumonia of the right side. You can have a lower lobe pneumonia of the right or left side. Pneumonia does not have to affect the entire lung. It doesn't have to affect the entire lobe either, but a lobar pneumonia does by definition. Normally, you can see the right border of the heart, like it's hidden by the lung, because it silhouettes against the upper lobe of the lung superiorly, and it silhouettes against the middle lobe of the lung inferiorly. And normally, you can see the left border of the heart in an X-ray because it silhouettes against the upper lobe of the left lung. If one of these lobes gets filled with fluid, which is what pneumonia is, then it will no longer have a different radiodensity than the heart. It will become a water density structure if it's filled with fluid, and therefore you will not be able to see the distinction between a pneumonic region of the lung and the heart. And here is, in fact, an example of it. This is a middle lobe pneumonia seen in PA view and in lateral view. This is what the middle lobe looks like, and here's the minor fissure and major fissure of the lung. But you can see that whereas we should normally expect to see a border of the heart on the right side, we don't see any border of the heart. It just merges right into what is the fluid-filled middle lobe. And similarly, you really can't see the upper border of the diaphragm here because it merges into the fluid-filled middle lobe. Even the right hemidiaphragm cannot be seen because of the silhouette sign of the merger of the image of a pneumonic lobe with the water density diaphragm. Here it is. I've told you what this is. This is a left upper lobe pneumonia. The entire left border of the heart is invisible, essentially, because it merges, in an image way, it merges with the pneumonic or fluid-filled upper lobe of the left lung. It's a somewhat difficult concept to get used to, but you will, I'm sure, before you graduate. All right. Do a chest film. You want to look at lungs for sure. All right. You also want to look at the heart for sure. And radiologists refer to the image that the heart makes on a chest film as the cardiac shadow or the cardiac silhouette. And it is more than just the heart itself. In radiologic terms, the cardiac silhouette includes the heart and the great vessels, such as now, we get into a problem here. I know you have not dissected the superior mediastinum. We're going to have to talk a lot about it today. So I will do some anatomy of the superior mediastinum as we go along. Similarly with the posterior mediastinum. I will have to do anatomy for you because you haven't dissected it yet. The superior vena cava, the ascending aorta and aortic arch, the pulmonary trunk and its branches, right and left, all of those things do not silhouette against the rest of the heart. You know, these are all water density structures. So you cannot tell where, the pulmonary trunk begins and the right ventricle leaves off, and you can't tell where the arch of the aorta begins and the left ventricle leaves off because the images all merge. They're all water density. So this whole thing, including the great vessels, is referred to as the cardiac silhouette or the cardiac shadow. And it would reflect terribly on us if when you left this course, you could not look at a chest film and identify the borders and the structures you're seeing in the cardiac shadow. And as badly as it reflects on us, it's going to reflect worse on you. What you're going to see when you're looking at a chest film is the right border of the cardiac silhouette is formed by the edge of the superior vena cava and the right atrium. That's it. Superior vena cava and right atrium. Maybe down here at the very bottom, sometimes you can see the inferior vena cava, which is has a very short intrathoracic course. It almost goes immediately into the right atrium. But those are the only possibilities on the right side. The inferior border of the cardiac silhouette is where the inferior vena cava meets the right atrium, mainly right ventricle, and the apex of the heart, the left part of the inferior border, is left ventricle. The most complicated border seen on a silhouette, a cardiac silhouette, is the left border of the cardiac shadow. You see the aortic arch, and you see the pulmonary trunk as bulges, a bulge for the aortic arch, a bulge for the pulmonary trunk. Then you see a little concavity here, which is the auricular appendage of the left atrium. The left atrium itself is behind the pulmonary trunk and ascending aorta. It's going to be invisible to you, completely blocked out by or merging with the images of ascending aorta and pulmonary trunk. All you can see of the left atrium is that little auricular appendage, which pokes out just to the left of the pulmonary trunk. And it usually is represented on x-rays we'll see by a concavity. And then most of the left border is the left ventricle. Now these, you have to absolutely know these things, what these borders are. Here are 3 examples of cardiac silhouettes. These are all quite normal. People shape it differently. Everybody's shaped differently. But let me go through the borders here. I mean, obviously, I can see the nice bulge of the right atrium here, very clearly in this person. Right atrium's almost flat in that person, and it's sort of intermediate in persons, like Goldilocks. I can clearly see in this person what must be the superior vena cava leading into the right atrium. I can't tell whether I can't see it here or because of where I am or not, but sometimes you don't see it well because you got the root of the lung there, which is hard. If there was an inferior vena cava, I know it's about right there, but I can't clearly, here I can't even see where it would be. Inferior border, I know what it is, but I can't tell one chamber from the other because they don't silhouette each other. So I know essentially this is where the inferior vena cava goes into the right atrium. I know most of this is the inferior border of the right ventricle, and just the leftmost part of this inferior border, including the bend, that's the apex of the heart, is the left ventricle. And I won't go through all of these, but you can do this yourself. Very clear individual variation shown in the left border of the heart. Let me go to the one which to me is most obvious. That big bump here at the top, that's the aortic arch. Here, it's a much smaller bump right there. And here, boy, I'll be damned if I hardly see anything at all, just right there. People are like that. Some people's aortic arches shoot more to the left. Some people's aortic arches go mainly backwards, and they don't make a big bulge. Here, it's very, very clear. If this is the aortic arch here, this nice bulge is the pulmonary trunk. On this one, here's the aortic arch. This bulge, pretty obvious to me, but not as big as the previous one, is pulmonary trunk. And on this one, looks to me like I want to call this pulmonary trunk. It's the only thing I think that could be. The little concavity right here, left auricular appendage. Right here would be the little concavity of the left auricular appendage, and right there. And then the big, long, bulging thing is the left ventricle. Not only do these people's hearts look different, even though they're quite normal, this person has something here that these 2 people do not have. That's because this person is a woman. And these are the shadows of the breast. Even though fat and breast tissue, unless you're actually lactating, is mainly fat. Even though fat density is pretty low, if you have large breasts, that adds up and gives you a noticeable density where the breast is. So these are 2 men and 1 woman. Something is wrong with this person.
It looks like there were 3 bulges, one here, and then this here.
You're right. You're absolutely right. He said it looks like there's 3 bulges above the left ventricle. Here's the border of the left ventricle. We only expect 2 bulges and 1 concavity. The 2 bulges are aortic arch, pulmonary trunk, and the concavity is the auricular appendage of the left atrium. So what is the 3rd bulge in your opinion?
Is it a blockage in the valve?
Well, you're dead on going to be correct. He says a blockage in the valve. What you're seeing here, this bulge, which should not be here, because here's aorta, right there. Here's pulmonary trunk, right there. That bulge should be a concavity. This is called left atrial hypertrophy, enlargement of the left atrium. And you talked about a block in the valve. This is most dramatic when, in fact, you have leaking mitral valves. In what's called mitral valve regurgitation. When the left ventricle contracts and blood gets shot through the valve back into the left atrium, that causes it to get enlarged, left atrial hypertrophy, and that gives you the most obvious bulge where you expect to see a concavity. It can also occur if the mitral valve is narrowed. That's called a mitral valve stenosis, but it's usually not as dramatic. How about this one? Anybody sure they know what it is? It's again a left border issue. Well, no one's sure, then I won't press it any further. Here's the aortic arch. Here's the pulmonary trunk. Here's the auricular appendage of the left atrium, concavity. Here's left ventricle. What's odd about this is that the pulmonary trunk bulge is about 2 to 3 times bigger than it should be. And this is caused by, it's a pulmonary trunk dilatation, caused by actually a narrowing of the pulmonary valve coming from the right atrium. And as that pulmonary valve narrows, the blood going through it comes out as a jet and hits...
What you said coming from the right atrium? You mean
Yes, thank you. No, thank you. See, Dr. Larson did what everybody should have done, which is correct me. All right? Coming out of the right ventricle. Not only should you all correct me when I make mistakes, but if you have any questions, as we're, now that I'm no rush today, I wouldn't have had time to answer questions last time, but you interrupt me to ask questions. Go ahead.
That area of opacity lateral to the pulmonary trunk, is that a normal finding?
Yeah, that's just normal vasculature of the left lung.
Okay.
So it's the blood coming out of the right ventricle, going through a narrowed pulmonary valve and being turned into a jet stream that hits the pulmonary trunk and pressure just blows it out, causes it to expand. So this, in fact, occurs as a result of a pulmonary valve stenosis. All right, so that's enough for cardiac shadows. All right, now we're going to do CTs of the chest. And the ability to read a CT of the chest, or an MRI for that matter, requires only 2 things. A good knowledge of the anatomic relationships of the structures in the chest, and an understanding of what looks white, black, or gray. All right? A knowledge of relationships is easily obtained by reading that chapter on core concepts on relationships 20 or 30 times. All right? So then after that, it's only what's, water density, bone density, or whatever. People do think, and past students have thought, gee, there's something really mysteriously difficult about learning how to read a CT scan of the chest. It isn't. It is no better way to review your knowledge of relationships than to try and read a CT scan of the chest. And that's the only information that's in there, really. All right. Just starting out with some of the bones that you expect to see. Here is, I can't remember if I used this. This is, did I talk about scar films last time? No one remembers. I don't remember, so I'll do it. When you take a CT of any part of the body, you usually have to take a regular plain X-ray with the same machine, and then you can project the transverse, this is transversus and axial section, you can project its level on your scout film. So this is a section that is at this level of the yellow line on this person's chest. So it's way up there. You can see the clavicles there. It's way up high in the chest. Again, I counted and know this to be the first thoracic vertebra. There's another hint that it's the first thoracic vertebra in that I can only see the first rib. If you're lower down, you see multiple ribs. You see multiple ribs in a section. We'll see that in a second. Here are 2 clavicles coming in. So when you're high up around T1, the top of the manubrium is not at T1. The top of the manubrium is typically at T2, T3. This is called surface anatomy. Typically, the jugular notch is at T2/T3. So the chest begins at the back at T1. It begins at the front at the jugular notch. So it has a different height in the front than it does in the back. It's taller in the back. But at any rate, we are therefore superior to the jugular notch of the manubrium. We're at the level of T1, and we're starting to see the clavicles as they are descending medially to, in fact, articulate with the manubrium. So if we go down 1, clavicles are still, now we see the first rib is starting to leave its articulation with the first vertebra, and it's going to wrap around, go down another level, that's happening even more, go down more, and now we start to see the upper edge of the manubrium, the jugular notch of the manubrium, and we know that the clavicles will end by articulation with manubrium. Now we start to see the second thoracic vertebra and its rib, the second rib. So now we see two ribs. We see the anterior part of the first rib and the posterior part of the second rib. And as we continue to go down, manubrium is getting more and more in our section. Clavicles are ending there. We start to see, now, this is another thing. This person's first rib on his left side is just about to join in the joint it has with the manubrium. On the right side, this person's first rib is still pretty far from the manubrium. That's not an anomaly of this person. These CT scans are often sort of oblique. It's hard to get a person to lie absolutely perfect so that their long axis is exactly perpendicular to the thing. They, little tilt in the person, and you'll see a little bit further distally on one side, further inferiorly on one side than the other. This is quite typical for there to be a little.
Jeff,
yeah.
Does the fact that the magnet things circle in a spiral contribute to that?
No, this was probably done before they had spiral CTs, but no, it doesn't, actually. You can see some which are perfect. You see some where everything is bilaterally exactly the same, and you see others where, in fact, if you look at the scout films, you can almost see the person, it's tilted like that. So, but I just like this because all the surface anatomy things match. So then we see we're in the middle of the manubrium here, first rib going down, continuing to go down. Manubrium's getting bigger. Clavicle is gone on the left side, but you get the very tip of it on the right side. Now both first ribs are joining the middle of the manubrium, and their costal cartilages are. And the second ribs have left, wrapping their way around. And we keep on going down and down. Now we have the third vertebra and the third rib, down and down. And now the second ribs are approaching what is the joint between the manubrium and the body of the sternum, which is called, as you know, the sternal angle or the angle of Louis. And here is the costal cartilage of the left second rib. And we haven't got quite low enough to see the costal cartilage of the right rib, but now we do. And this, in fact, is the joint between the manubrium and the body of the sternum, where the ribs join, where the second costal cartilages join the sternum. And now, and I won't do any more of these, all these sections I say are available. Mediastinum has 4 named regions, as illustrated here. The big part is the middle mediastinum, in which the heart and pericardial sacs sit. Also the roots of the lungs are said to sit there. That's the middle mediastinum. That you have dissected most of, or all of, all right? Today, you're going to dissect what's in the superior mediastinum and posterior mediastinum, and no one dissects what's in the anterior mediastinum because there's nothing there, all right? Unless you're a baby. We'll talk about that later. Anyway, the middle the superior mediastinum is defined as that portion superior to the pericardial sac. Posterior mediastinum is defined as that portion posterior to the pericardial sac. The pericardial sac and the roots of the lungs are in the middle mediastinum. I'm going to look first at the structures of the middle mediastinum, then we'll look at the structures of the superior mediastinum, and then we'll look at the structures of the posterior mediastinum as seen on the CT. So, see if this is going to work out. Here is the same picture we saw. I've indicated here the sternal angle because in your typical, and I put that in triple quotations, in your typical lying down patient, the junction between the superior and middle mediastinum is at the sternal angle. That is where the roof of the pericardial sac lies. With a lot of variation, but that's, you've got to remember something. And so that's at the sternal angle, more or less indicates the boundary between superior and middle mediastinum. Something should be happening here. All right. I'm going to start out with a section that is not through the middle mediastinum. I'm going to start out with a section which is in fact through the superior mediastinum, through the lower part, inferior part of it, because it goes through the aortic arch. It's the simplest section you can get in the CT of the chest. It has the fewest things in it, and is the easiest one to start identifying things in. It's going to have the aortic arch in it. It's going to have to the right of the aortic arch the superior vena cava. It's going to have to the left and posterior to the arch the trachea. And behind the trachea, which we cannot see in this picture, it's going to have the esophagus. Those are the 4 things you're going to see in a section through the aortic arch near the bottom of the superior mediastinum. Then I'm going to go down to a section exactly through the sternal angle, and that corresponds to the concavity, the lowest point in the concavity of the aortic arch, also corresponds to the highest point in the bifurcation of the pulmonary trunk. And in that section, we're going to see what is essentially the ascending aorta, right near its junction with the arch. We may clip the top of the pulmonary trunk bifurcation to the left of the ascending aorta. We will certainly see the superior vena cava to the right of the ascending aorta, and we'll continue to see trachea and esophagus. We go down another level. In the true middle mediastinum, we're going to see ascending aorta with the pulmonary trunk to its left side and the superior vena cava to its right side. And we go down even further, we're going to see where the pulmonary trunk emerges from the right ventricle. We are getting close to where the ascending aorta emerges from the left ventricle. That's going to be posterior to this. We're going to clip the top of the right atrium, where the auricular appendage of the right atrium is. And we will probably clip a bit of the auricular appendage of the left atrium. And if we go down further yet, if I could get this thing to work properly, all right, we're going to go right through the middle of the heart, and we're going to see right atrium, and we're going to see the right ventricle sitting up front in the front of the chest, because it is the anterior chamber of the heart, and then we're going to see the left ventricle here. And where we would have seen the left atrium, well, we already talked about seeing the auricular appendage. We'll see the rest of the left atrium here behind the ascending aorta and pulmonary trunk in the previous section. That one there. We'll see this one here. We'll see left atrium, the part we can't see, which is behind pulmonary trunk and ascending aorta. So I've told you pretty much all the relationships you need to know. And down near the bottom there, a little bit of right ventricle and left. So here's the first image I told you, the simplest image in a CT of the chest. This is the aortic arch. Starts a little bit to the right of the midline anteriorly, ends up a little bit to the left of the midline posteriorly. Aortic arch actually tends to head more front to back than right to left. In this person, in everybody, it tends to do that, but there's variation here. So this is the aortic arch. The structure that I said would be to the right of the aortic arch is the superior vena cava. The structure I said would be air-filled. Now, those are all water density structures. They're filled with blood. Then there's an air density structure, which is behind and to the right of the aortic arch. That air density structure behind and to the right of the aortic arch is the trachea. And then the thing that is behind the trachea is this thing here, which looks to be partly water density and partly air density, and that is the esophagus. Now, the esophagus really does tend to be a little bit to the left of the trachea, even though it didn't come across in Netter's drawing. The esophagus is usually not right behind the trachea. It's usually a little bit behind and to the left of it. And that would have been enough for me to tell you that that was esophagus, but the fact that there's a little air density bubble in there is even better. Because there's not much air in your chest other than what's in your lungs and trachea, except what you swallow. And so there's a little air bubble, and people, you won't be in everybody. It depends on what stage of swallowing this person was at when this was taken. But we all swallow air constantly. It's not uncommon at some point when you're looking at the esophagus in a CT scan to catch an air bubble that's in it. And so, because you can't think of anything else that would have an air density sitting in the middle of the chest other than the trachea. So if we go down now, we see we're going down from the arch to where the ascending aorta, and here it is. Here's the ascending aorta starting to come up to make the arch. Here's the descending aorta, 7, starting to leave the arch and heading down along the back. That's part of the posterior mediastinum, so we won't spend any more time on it. I also point out that as we go down, the trachea starts to get wider and wider and then splits as we get to the tracheal bifurcation, which is just at the level of the sternal angle, really, or just very much the level of the sternal angle, which it corresponds to the concavity of the aortic arch. 2 was always the superior vena cava. It was the superior vena cava when it was to the right of the arch, and superior vena cava when it's to the right of the ascending aorta. But we are now to the left of the ascending aorta start to get the very top of the pulmonary trunk bifurcation, which is to the left of the ascending aorta. If we continue down, again, ascending aorta, pulmonary trunk bifurcation, trachea is split even further into a right main stem bronchus and a left main stem bronchus. And we go down further yet, and we see a much clearer pulmonary trunk, and we can identify this really as a branch of the pulmonary trunk, the left pulmonary artery. Ascending aorta hasn't changed. Superior vena cava hasn't changed. We go down one level further. We see a beautiful bifurcation of pulmonary trunk. Left pulmonary artery, right pulmonary artery. Superior vena cava hasn't changed. Ascending aorta hasn't changed. And further yet, we see we are below, essentially, there's very little of the left pulmonary artery here. We see the left main stem bronchus. The right main stem bronchus is sort of seen here, but it's sort of blown out. Here's the right pulmonary artery. Again, ascending aorta, superior vena cava, those things haven't changed. Now, we are down, as I said, when you start to go down, eventually you're going to clip the top of the right atrium. And that's what we've got here. Here's the superior vena cava and entering the right atrium at this site. And here is the auricular appendage of the right atrium, which runs forward and sort of hugs the ascending aorta, number 6. And now the pulmonary trunk is starting to work its way down to the right ventricle. This is still, what is that? Why did I leave a question mark there? Oh, I know why I left a question mark there, because I wasn't sure what it was. Here was very clearly right pulmonary artery. Here's very clearly right pulmonary artery. I know from my study of anatomic relationships that the right pulmonary artery runs on the roof of the left atrium. A fixed relationship in everybody. The right pulmonary artery runs on the roof of the left atrium. When I got down to here, I still thought that was right pulmonary artery. When I got down here, I couldn't tell you anymore. Am I looking at right pulmonary artery, or am I looking at the roof of the left atrium? They're going to blend with one another. And if I go down one, I clearly have left atrium. So I didn't know right at the boundary between them what I was seeing. Here's still ascending aorta hasn't changed, pulmonary trunk. I've decided that this little most anterior part of the shadow of the pulmonary trunk is probably where the right ventricle empties into the pulmonary trunk. This is left atrium. I told you it was posterior to the ascending aorta and pulmonary trunk, and it is. And this is that little bit of the left atrium which hugs the edge of the pulmonary trunk. That's the auricular appendage of the left atrium. As I go further down, we now clearly see that this is going to be the right ventricle. The right ventricle sits on the anterior surface of the heart. It is the anterior chamber of the heart. Here's the right atrium. We still have ascending aorta. It hasn't yet exited from the left ventricle. We have left atrium, the most posterior chamber of the upper half of the heart. We just now start to see a little bit of the left ventricle coming in. And now we see more of the left ventricle. We see a very clear right ventricle. How do I know this is right atrium? It forms the right border of the heart. The only chamber of the heart that forms its right border is right atrium. That's it. Can't be anything else. The anterior surface of the heart is largely formed to the right ventricle. So that's what this must be, right ventricle. Left atrium sits behind ascending aorta. Still left atrium. Now we see the ascending aorta emerging from the left ventricle. Right ventricle is where it was, right atrium is where it was. And I can go down through these others because nothing is going to change until we get down below the inferior border of the left atrium. And that's going to happen very soon. Right here is where it happened. How do I know I've passed the left atrium? Of course, here I see it. Here I see it. I don't know if I see anything there. Here I see a structure which runs along the inferior border of the left atrium that you dissected out, that carries venous blood. And it's called the coronary sinus. So that's how I know that I'm below left atrium, because I can see coronary sinus runs along the left. Here's the right ventricle, forming most of the anterior surface of the heart. Left ventricle forming at this level all of the left border. Right atrium, the only thing that can form the right border that's part of the heart. And Finally, we get down far enough where we see the inferior vena cava starting at its point of entry into the right atrium. And now we are below, essentially, the point of entry of inferior vena cava to right atrium, and it's going into the abdomen. All right, so that's the basic heart anatomy you see in CT. Nothing but relationships in what you already know. I showed you a CT without contrast, all right? Lots of people get CTs with intravascular contrast. They put a catheter in your antecubital vein, and they inject a radio-opaque substance and follow it through your circulatory system. Now, depending upon when you take your CT, and they are timed, it'll be almost entirely in the venous side of the system, or the right side of it, and then it will eventually travel to the left side of the system, out to the systemic arteries. Now you can see, here is a person who's had contrast. You can see, we've already identified everything in this. Now, it's pulmonary trunk, right pulmonary artery, left pulmonary artery. To the right of the pulmonary trunk is the ascending aorta. To the right of the ascending aorta is the superior vena cava. Well, here the superior vena cava is brilliantly white because it is filled with radio-opaque contrast material that's been injected into a vein of the arm, which is draining into the superior vena cava. The aorta, ascending and descending in the pulmonary trunk, they all stand out much clearer when you have contrast. So putting contrast in a person enables you to see things a lot better, but it doesn't change where they are. Right? Here's a person, here's just the heart with contrast. You can see now, you can see the left ventricle, how thick the wall of the left ventricle is, because here's the contrast filling this chamber. You can see the left atrium here, and it's a much thinner wall. This must be the mitral valve right there. Here's right ventricle and right atrium. Their positions haven't changed. And obviously, most of the contrast material is found on the right side of the heart. And maybe this is the tricuspid valve. I don't know. Maybe not. You can see the interventricular septum, because now the chambers are filled with a radio-opaque substance which has a different density. There's other things that can alter the way CTs look. This is a person who has metastatic carcinoma to her lungs. And the heart looks fine. These lungs have all sorts of things in there that shouldn't be there. It looks like she's got a tremendous number of metastases to the lungs. That's with an X-ray, a CT done for what's called soft tissue density to show the heart best. If you want to change the parameters of your CT, you can do it to show your lungs better. And that's what this one is. And when you do that, you don't see the structures in the heart nearly as well, but you see that she's got tumor in more of her lung than you thought ever before. So how you show a CT, whether you use what's called tissue density or lung density, affects the way things look. Right? This is just a reformatted version of the same person. Now, this lecture is going to go on forever. Good. You know this already, right? Boy, you do. You've dissected it. You know there's an LAD, anterior ventricular artery, coming off the left coronary. You know that the left then turns into the circumflex. That the circumflex usually gives off what's called one or more obtuse marginals to the left ventricle. You know the right coronary artery comes off the anterior aortic sinus, travels in the right atrioventricular groove, gives off a branch called the acute marginal to the right ventricle, and then wraps around to the back of the heart, the right coronary artery does, and then gives rise to the posterior descending or posterior interventricular. So that's review. Coronary angiography can show you all of those things beautifully. Used to be that to see a person's coronary vasculature, you had to put a catheter through their femoral artery and up through the aorta and inject contrast right into the coronary vessels. Now, you can just do a regular contrast CT, and the resolution is so good, and the ability to see things magnified is so great that you can actually see the coronary vasculature. So it's a much easier study to do, and it can be done on almost anybody. It's called a CT angiogram. So this is a familiar picture. This is pulmonary trunk, to the right of which is the ascending aorta, to the right of which is the superior vena cava. These little bulges here, those are the sinuses of the pulmonary valve. That means the pulmonary valve must be right here. That means this must be right ventricle. Right pulmonary artery, left pulmonary artery. I'm going to follow this down. We're going to start to see all sorts of things appear that we're not going to have a clue as to what they are. I don't know what number 1 is. Doing something. Number 4, I don't know what that is. Let me follow them out. 3, no clue. 2, now we start to see something that I can probably identify. 2 is coming from, here was our ascending aorta. Let's follow the ascending aorta down. We're following the ascending aorta down, 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 down. Little bulges, the sinuses of the valve, of the aortic valve. And we see number 2 as coming off the left posterior sinus of the aortic valve. And the artery that comes off the left posterior sinus of the aortic valve is the left main coronary artery. So that tells us what all these others are. Let me go back up again. 3 is a posteriorly directed branch of the left main coronary, so 3 must be the circumflex. 4 was a leftward branch, that must be an obtuse marginal. 1 is an anteriorly directed branch, which in fact is going to take up position here in the anterior interventricular sulcus. So 1 must be the LAD. What about 5? 5 we see as a branch coming off the anterior sinus of the aortic valve. There's only one artery that does it. That's the right coronary. We can trace it to the groove between, here's the right atrium, here's the right ventricle. We can trace it to the right atrioventricular groove, which is where the right coronary lies. And then we see its acute marginal branch being given off along the right ventricle. And then we see the right coronary turning around onto the back of the heart, coming down here. We'll worry about that later. Coming onto the back of the heart. But this is the posterior descending. How do I know? Because, in fact, it's going to anastomose with the LAD, which is the left anterior descending. This thing, I don't know what it is. What was this thing here? I thought 9 was part of the coronary sinus. For the remember, here was, I'm going way up now, here's our left atrium. Here's probably where the mitral valve is. Here's the interventricular septum. If I look at our left atrium getting smaller and smaller as we go towards its inferior boundary, it gets so small, and then we pick up this vessel there. So that's probably the coronary sinus going into the right atrium. So you can do volume renderings of these vessels, and you can see what the heart actually looked like. I put more of them. You can subtract the heart itself and just show the vessels by it, and you can do something even cooler than that, which I don't know how they do. And I don't know, but this is worth watching.
The CTA gives us the opportunity to examine the coronary arteries, and the clarity of the pictures that we get is truly extraordinary. What we see now is the heart beating. On the left-hand side here, we see the right coronary artery, and this is the left anterior descending coronary artery, followed by the circumflex vessel. These are the 3 major coronary arteries of the heart. If this patient had coronary artery disease, we might see blockages. It would look like a pipe that has a pinched section of it. We can then get a cross-sectional view of whatever narrowing there is and the kind of plaque that's responsible. This is a view of the aortic valve now, the blood leaving the left heart, going through the aortic valve, being pumped out to the aorta and to the rest of the body. We see the 3 leaflets of the aortic valve opening. This particular case had normal coronary arteries and normal valvular structures.
Must be tricuspid, I'm guessing.
The contraction of the heart was a little bit weak. The left ventricle, again, is coming into view. This is the left atrium, separated by the mitral valve. We see the chamber contracting here, a bit weakly. The blood is then entering the left ventricle, being pumped out through the aorta. And again, we see the right coronary and the left anterior descending and circumflex coronary arteries. The heart, of course, is covered by the rib cage.
So one has to see that because it's just too cool to understand what you can do nowadays with just CT angiography and the computer volume rendering of it. Now we're going to go and look at the superior mediastinum. It'll go more quickly. I'm going to start again through the aortic arch, so we expect to see the superior vena cava to its right. We expect to see the trachea to its right and behind that the esophagus, and then we're going to go up. And then we'll come to the formation of the superior vena cava by the left and right brachiocephalic veins, and that'll be very close to where the beginning or the origin of the brachiocephalic artery is. We go up higher, we should really see a very nice separate left brachiocephalic vein and right brachiocephalic vein, a nice brachiocephalic artery, and we'll probably catch the left common carotid and subclavians too, which are coming off sequentially. And again, the trachea and esophagus will be there as well. And then eventually we'll get to the point of bifurcation of the brachiocephalic artery into the right common carotid and right subclavian. So we know this by heart. Quickly, aortic arch, superior vena cava, trachea, esophagus. Going up a level. We're getting near the top of the aortic arch, but we haven't, and we're getting near the formation of the superior vena cava, but we're still below them. Now we actually start to see the formation of the superior vena cava through the junction of the left brachiocephalic vein with the right brachiocephalic vein, and we start to see the branches that are emerging from the aortic arch. Brachiocephalic artery anterior to the trachea, that's a fixed relationship generally. Brachiocephalic artery anterior to the trachea. The next branch to come off will be the left common carotid, and the last branch to come off will be the left subclavian. Trachea and esophagus haven't changed. Go up higher yet, very clear, 3 branches off the aortic arch. Brachiocephalic, left common carotid, left subclavian. We now see a very clear separate left brachiocephalic vein and right brachiocephalic vein. And if we just trace those things up, 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 we start to see the bifurcation of the brachiocephalic artery into its subclavian, and right common carotid. So you just know your anatomy of the superior mediastinum, everything falls into place. Posterior mediastinum. We're going to sweep down the posterior mediastinum, but there's no picture of it here. Posterior mediastinum consists essentially of 4 structures. The descending aorta, which is on the left anterior side of the vertebral column. The azygous vein, which is on the right anterior side of the vertebral column. And in between them, the thoracic duct. That's a fixed relationship. Descending aorta, then thoracic duct, then azygous vein. You don't even know what the azygous vein is, do you? Right? If you read ahead, you. Azygous vein is a big vein that drains the intercostal spaces. And I actually showed it on a CT previously as joining the superior vena cava, but not important now. It is a major body wall vein draining the intercostal spaces, and it's always in the it's always to the right of the descending aorta, and always to the right of the thoracic duct, which lies in between them. And the esophagus comes back and starts out sitting anterior to the thoracic duct, and then as it descends, moves on to anterior to the aorta. We can go through this very quickly. Here's just a cross-section showing absolutely never violated relationship of descending aorta, next to which is thoracic duct, next to which is azygous vein, and the esophagus anterior to the thoracic duct through much of its course in the chest. I've also put in the hemiazygous vein, which is a vein behind or posterior to the descending aorta. These things, here is our section we know about. Aorta, arch, superior vena cava, trachea, esophagus. Here's the azygous vein. What I couldn't show you, which you just have to see, the azygous vein, which runs on the right anterior part of the vertebral column, is going to eventually empty into the superior vena cava. We see that right here, quite high in the chest. Obviously, we still have a bit of aortic arch there. But we'll follow number 2 down, which is the azygous vein. And that little, boy, can you see a dot there? Neither can I. That thing you cannot see is the thoracic duct. All right, but sometimes it'll look better. Looks sort of better there. But this picture here of descending aorta, thoracic duct, azygous vein, with the esophagus anterior to the thoracic duct, is what we're going to see the whole course. All the way down, 5 is the hemiazygous vein. So this is just those relationships are invariant all the way down. thoracic duct, esophagus vein, thoracic duct, descending aorta, with the esophagus anterior to the thoracic duct. But eventually you'll see the esophagus will start to move anterior to the aorta. So that, it's really not hard. The rest of this I will actually go through quickly, because you've learned now, essentially you've learned everything there is about relationships, and you can apply. MRIs of the chest are not done as often as our CTs. They're not terribly revealing. This is, again, just to remind you that in an MRI, some things, in a T1, this is a T1 weighted MRI, some things are always black. Air is always black. Cortical bone is always black. So here's the cortical bone of the vertebra right there. Here's the black cortical bone of the manubrium right there. Fluid, which doesn't have a lot of protein, is black. So cerebrospinal fluid here is pretty black. And flowing blood, even though it might have protein, is black. So there's a lot of black things, which makes it hard to tell everything from one another. So I've just pointed out to you, here's the CT, which you now know absolutely cold. The MR at the same level just shows you, the big black thing is the trachea with brachiocephalic artery anterior to it. This must be left common carotid, that must be left subclavian. If you can see the beginnings of the brachiocephalic artery, which is anterior to the trachea, then you know the left brachiocephalic vein is crosses anterior to the brachiocephalic artery. And that means if that's the left brachiocephalic vein, that must be the right brachiocephalic vein. And I've not labeled these, but you can do the comparisons yourself. Look how funny the superior vena cava looks in this person. Just looks flat. It depends. Sometimes there's a lot of blood flowing through it, sometimes not so much at any moment in time. But all the other things look the same: trachea, esophagus, aortic arch, pulmonary trunk bifurcation, everything. You can go through this yourself. So, now, and again, I don't have time, and wouldn't have done it even if I had time. Because I want to show you some neat things. These are all on the web, all these coronal sections. These are coronal magnetic resonance imaging sections. So now we're going from the front of the person to the back. And the easiest thing to realize is when you're starting at the front and going backwards, the first chamber of the heart you're going to get is the most anterior chamber of the heart. What's that? Right ventricle. That is the anterior chamber of the heart, the right ventricle. It's the one that sits up against the sternum. So when you start in the front and head backwards, you're going to get number one, which is the right ventricle. That's the first thing you're going to see, essentially. And then, in this particular case, we also get a little bit of the left. And we follow number one, and you see it's going to turn into the pulmonary trunk. Number three, the pulmonary trunk, that three is it's called the pulmonary infundibulum. Narrow the ventricle to enter the pulmonary trunk. Three is the pulmonary trunk, and then it's going to branch into, pulmonary arteries. And if we go back, here we are towards the front again. We take a look at our left ventricle right here. It's going to give rise to an aorta. There it does. Here's the aortic valve. There's the ascending aorta. The aorta is going to come and swing up as the arch. And the arch is going to give off a brachiocephalic artery. But of course, crossing in front of the brachiocephalic artery is the left innominate vein, or left brachiocephalic vein. So that's number 7. And then when that disappears, we see the brachiocephalic artery. You see the superior vena cava and right atrium. You go through these on the right. It's just a knowledge of anatomy, nothing more to it than that. Now, there's another thing, which I'm just going to tell you exists, and there's some pretty pictures on it, that, again, I have no way of explaining how it's done. I told you that flowing blood looks black, and we saw that ourselves. Here, we saw it here. Here's the coronal MRA. Flowing blood is black, very dark gray. There's a way to set these magnetic resonance machines to make flowing blood white, and it's called magnetic resonance angiography. And that's what this is. Same thing we just saw, except the flowing blood is white. So again, the anterior chamber of the heart's right ventricle, left ventricle. We follow the right ventricle up to the pulmonary infundibulum, then to the pulmonary trunk, and the bifurcation of the pulmonary trunk into right and left, and we see the right pulmonary artery running on the roof of the left atrium, as I said. If we go back again, we see the left ventricle giving rise to the aortic valve, the ascending aorta, and again, arch of aorta, brachiocephalic artery, left common carotid artery, and subclavian. So you just see these things as well as if you were dissecting. It's called a magnetic resonance angiogram. And this is just a sagittal section of the same magnetic resonance angiogram. Again, if anybody shows you a sagittal section of the heart in imaging, the anterior chamber is the right ventricle. That's it. If you don't remember anything else, remember the anterior chamber is the right ventricle. So that's what this thing is here. All right. And here we see giving rise to the pulmonary trunk, and we see the bifurcation. And we go to the left ventricle, which is this one here. Here it's giving rise to aortic valve, ascending aortic, oops, wrong, aortic valve, ascending aortic, arch of aortic, brachiocephalic artery, left common carotid artery, left subclavian artery, in sequence. And you can do these yourself. You can, when you do a magnetic resonance angiogram, subtract everything but the vessels. Is this moving? So you can just look at the vessels if you want. Let me see if I can move this. I do. You can rotate it around and look at all the vasculature coming out of the heart in detail. Or you can make a motion picture of magnetic resonance angiogram. This is an actual beating heart. Seen a magnetic resonance angiography. This is a mid-sagittal section. So one thing we're 100% sure of, this is the most anterior chamber. What is it? Right ventricle. That's correct. That's an important thing to know. All right, right ventricle. In fact, there's a clinical sign where the sternum sort of bulges or moves every time a person has a heartbeat. And that's due to a sign of right ventricular hypertrophy. It's called sternal heave. Sternal heave. Every time your heart beats, the large right ventricle, when it relaxes, pushes the sternum forward. And so you get, so that's the only way you can understand it is if you know the right ventricle is the anterior chamber up. Here is going to be the, I think, left atrium, left ventricle. There's the aortic valve, very clearly, and the ascending aorta. If this is left atrium, here's a vessel which is running across the roof of the left atrium. Anybody remember the vessel which runs transversely across the roof of the left atrium? Well, you will on Tuesday. That is the right pulmonary artery. So you can see the left atrium emptying into the left ventricle. You see blood coming out of the aortic vestibule and through the aortic valve into the ascending aorta. You see the right pulmonary artery. It's probably left pulmonary artery. I don't know what that is. And so that's right down the middle, a mid-sagittal section. Here's one to the left of the midline. So we're now further to the left. We're so far to the left that we are beyond the margin of the right ventricle. You know, the right ventricle is the anterior chamber of the heart, but if you go far enough to the left, the anterior surface of the heart is made up by the left ventricle. And this is all left ventricle and left atrium, and things going through the mitral valve. This looks to be the aortic arch here, and that looks to be one of the vessels coming off the aortic arch. Here's to the right side, to the right of the midline, far to the right of the midline. Anterior chamber here must be right ventricle. This is superior vena cava and inferior vena cava, and somewhere around here must be right atrium. So you can see an awful lot about this person's heart functioning by doing a movie of magnetic resonance angiogram. And now this is just a coronal section. These are just two next stuff to watch. Let's see where's it put. So this is left ventricle, right ventricle. This must be right atrium here. And that must be the tricuspid valve there. Some things I might not be able to identify, and you might. This must be, yes, left atrium. Going into the left ventricle. You can step right, you can't step. Yeah, I put these on the left. Now, a disease. First of all, what do you figure we've got here? This is a coronal magnetic resonance angiogram, but it's not right at the front. It's sort of working its way towards the back. Obviously, this big thing here is the left border of the heart. That's the left ventricle. This must be the aortic valve. This must be the ascending aorta, the beginning of the arch. This is must be the pulmonary trunk. Anybody want to venture a guess? Back left. Yeah. This is an incompetent aortic valve. And again, I don't know what makes flowing blood look one color now, but when you have this jet of blood coming through an incompetent aortic valve called aortic regurgitation, it shows up like this on a magnetic resonance imaging. And then the last slide is, I guess I should tell you, is the sagittal section. I didn't make it clear. It's a sagittal section, so the person's anterior body wall is here, here's the posterior body wall, back here somewhere. So we're looking at a sagittal section. So this is towards the front, that's towards the back. If this is the brachiocephalic artery, I know that the thing which crosses it in the front at its origin is the left brachiocephalic vein. Just pure from an anatomic relationship. If you can identify something as a brachiocephalic artery, the thing which crosses it in front is the left brachiocephalic vein. It's this thing here which sits in front of by the ascending aorta, and in front of the left brachiocephalic vein, and in front of a part of the heart itself. It sits in the anterior mediastinum. What do you figure it is in a 7-year-old female? A horrible disease? It's your thymus. Thymus is a structure that in your cadavers will look like nothing. Globs of fat, if anything. But when you're a youngster, the thymus is an important immunologic organ. It is big and sits in the anterior mediastinum, in the superior mediastinum, and descends into the anterior mediastinum as it does here.